We are covering fractures and orthopedic trauma, a major topic on the NCLEX. The exam focuses heavily on your ability to recognize and manage life-threatening complications rather than just identifying different fracture types. Whenever you encounter a question involving a new fracture, particularly of a long bone like the femur or a crush injury, your immediate priority must be a thorough neurovascular assessment. This step precedes everything else, including the administration of pain medication. This is where the essential mnemonic of the 5 Ps becomes critical for recall. These are pain, paresthesia or tingling, pallor or paleness, paralysis or inability to move, and pulselessness. A 6P, poikilothermia, which refers to a cool extremity, is also a key indicator. A common exam trap involves a scenario with a patient reporting severe, escalating pain. The tempting answer is to administer an ordered analgesic. However, the correct first action is to perform a comprehensive neurovascular check using the 5 Ps. This priority assessment leads directly into the most frequently tested orthopedic complication, compartment syndrome. This is a surgical emergency that occurs when pressure builds within a muscle compartment, typically restricted by a new, tight cast or severe swelling, which compromises circulation and nerve function. The classic sign that NCLEX expects you to identify is pain that is out of proportion to the injury. Another telltale sign is severe pain on passive stretching of the digits. For example, if a patient with a forearm cast reports a 10 out of 10 burning pain unrelieved by opioids, and you gently extending their fingers causes extreme pain, you must suspect compartment syndrome. A common mistake is to elevate the limb, but for suspected compartment syndrome, the limb should be kept at heart level, as elevation can decrease arterial inflow. Your immediate action is to notify the provider. Pulselessness is a very late and ominous sign, indicating irreversible damage may have already occurred. The exam will test your ability to intervene at the earliest sign, which is the unrelenting pain. Next, you must be able to differentiate compartment syndrome from another deadly complication, Fat Embolism Syndrome, or FES. This is most associated with fractures of the large long bones, such as the femur and the pelvis. In FES, fat globules are released from the bone marrow into the bloodstream, traveling to the lungs, brain, and skin. The NCLEX will present a scenario that might sound like a pulmonary embolism, but there is a key distinguishing feature. A patient with FES will exhibit a classic triad of symptoms: respiratory distress, neurological changes like confusion or restlessness, and a petechial rash across the chest, axilla, and neck. This rash is the definitive sign that should immediately make you think of FES. Recognizing this triad is crucial for selecting the correct interventions, which include fracture immobilization, respiratory support with oxygen, and close hemodynamic monitoring. Finally, let's address nursing care for traction. The NCLEX loves to test safety principles here. For any patient in skeletal or skin traction, the absolute rule is that the weights must hang freely at all times. They cannot rest on the floor or the bed frame. As the nurse, you must never remove or lift the weights without a direct provider order, as this would interrupt the fracture alignment. Your responsibilities include ensuring the ropes are in the pulleys, maintaining body alignment, assessing for skin breakdown, providing pin site care with sterile technique to prevent osteomyelitis, and of course, continuously performing those crucial neurovascular checks on the affected extremity. In any orthopedic scenario, if you are asked to prioritize, a thorough assessment of circulation, sensation, and movement will almost always be your first and best action.